Welcome, everybody. I'm going to talk about radial access in PCI today, and just by way of some perspective or context. For so many years, I gave this talk trying to convince people that radial PCI is a good thing, but I hope this year I have to do much less of that. And so I'm not going to spend as much time on the data in support of that, but I will spend some time discussing some of the trials. This is the outline. I just want to go through some of the history because I enjoy medical history, and it also gives us some understanding of why we do what we do, to understand what we've been through. I have a section on my own tips and my very biased points of view, which I admit are more or less based in data, more probably based in personal experience. So I'll try to make sure I disclose my biases clearly. And then I want to spend some time on radial artery occlusion and recent data, which has come out in the last year or so on distal radial access, and then kind of finish with best practices. So historically, the concept of using the radial artery for arterial access is been around for a long time. The first report of transradial coronary angiography was actually from the Montreal Heart Institute. This paper by Lucien Kempo was actually in CCI. It was called CCD at that time. Didn't have the interventional flavor. In 1989, saying that, it was successful. I think it was 100 patients. They used a 23-centimeter sheath. Not a specific radial sheath, but a 23-centimeter sheath, which for those of us who did these things before these specific radial sheaths, it could be quite an adventure to use a long sheath in a radial. And they reported two types of complications: brachial dissection and then radial artery occlusion, which occurred in 1 out of 100 patients. So this paper inspired Dr. Kimene, who in Amsterdam kind of points to that paper from the Montreal Heart Institute as an inspiration. Dr. Kimene is an interventionist in Amsterdam, and at that time he was doing transfemoral interventions, and the stents were available in Europe before they were available here. Implanting stents, Coumadin anticoagulation, after femoral punctures led to the same thing that we experienced a little bit later, terrible groin complications, pseudoaneurysms, surgery. And so when he saw this report about transradial coronary angiography, he decided that might be a good thing for interventions. And so in 1993, he reported his first case series of transradial PCI. So in general, he's considered to kind of be the primary innovator of radial access PCI. It wasn't until 15 years later that we kind of started in the New Haven area. I remember Greg Singer and I, in November of 2008, did our first few cases in West Haven, and very reluctantly brought my partners along. And then another milestone, I would say, is that by 2014, Eric Stilp was one of the interventional fellows at that time. They rotated for 3 months at a time at the VA, and at the end of his interventional year, he did 100% of his cases, angioplasty cases, via radial access in the last 3 months of his interventional fellowship. There's Eric. The other notable thing about Eric is he's the only person who I know of who pulled out previously placed coronary stent, not intentionally, but it ended up working out fine. Um, I think that was in May of 2014. So the road to our current level of acceptance of radial access was not always clear. This is a famous quote from July of 2013. One of the interventional attendings told the fellows, the new interventional fellows in that month, if we get called in and you're in the wrist, I'm going to kill you. So it was not a smooth transition to my partners, and I won't name names here, but I think I put this quote up there because it emphasizes that there was resistance to moving to radial, both from attending staff and cath lab staff, technicians, nurses, any kind of major change people get uncomfortable with. So I want to put radial access in kind of a greater context of angioplasty interventional changes, or the timeline. The first coronary stents, wall stents in '86. ReaPro, which is the first 2B3A inhibitor, which was marketed as something that could be used in the place of a stent, was in 1994. The Pfau shots stent for coronary applications was approved in this country in 1995. Drug-eluting stents were approved in 2003. So all of these things, the entire focus of the first 25 years of angioplasty really was to kind of make a difference and to make sure that we eliminated ischemia, both in the short term and the long term. So all of the technical innovations, all of the literature, all of the publications really focused on how to get a safe, durable result in terms of dilating a coronary and making sure that patient was ischemic. And then OASIS 5 is an interesting study. So OASIS is a series of clinical trials in angioplasty, and OASIS 5 was designed as a comparison of Lovenox, enoxaparin, and fondaparinol for acute coronary syndrome. But one of the papers that came out of that study was observational data from Europe that noticed the mortality difference between those patients who were in this trial and had radial access for their PCI and those that had ephemeral access PCI. So it was a sub-study. It was not part of the primary design of the trial, but it was an observation that kind of stirred a lot of controversy in the literature and at national meetings. Most people didn't believe it was really true. It was some kind of strange quirk of the trial or the trial design. And that kind of ultimately led to Rival, which was the first randomized trial of transfemoral versus transradial angioplasty, which the findings were published in 2011. And I think it's fair to say that now, 2022, we've kind of moved 11 years later to where radial access is a standard. I'm not aware that anybody's particularly opposed or thinks it's a terrible idea to go radial. And that kind of shift defines, or kind of moved us to what I think is an era where we're focused very much on complications of angioplasty, especially bleeding complications. Anybody who's gone through the interventional literature in the last 5 to 10 years, the number of studies out there, kind of bleeding avoidance, that term was coined probably in 2005 or 2007, bleeding avoidance. And so really there's quite a bit of research and literature dedicated, and a lot of it centers around radial access. So I promised I wouldn't go through all the trials, but I just want to mention Rival because it's a funny story. So 7,000 patients with acute coronary syndrome, the minority had STEMI, 158 centers, 32 countries. So big, huge trial. And this is the, the primary endpoint was statistically different, and even bleeding did not achieve statistical difference. And so overall, it was a negative trial, which was a disappointment for those of us who kind of were advocates of radial access. And it was quite controversial. In fact, it was presented at this conference as a journal club. So Yassine, I told you I would call on you, and here we go. Which current Yale interventional faculty member presented the rival trial at Interventional Conference Journal Club? And importantly, to your answer, took great pleasure in repeatedly emphasizing that it was a negative trial to me. He really had fun giving me the business about that. So who would you guess on this list?
I'd guess B.
Dr. Shah. Interesting. Okay, well, it's not Dr. Radaran, so we can give Dr. Radaran's way too polite to give me a hard time about that. It's not Dr. Canby. He's handsome, but he's too old. His time was way before 2011. It's not Dr. Curtis. I think he's closer to Canby than to 2011. And Dr. Shah is way too young. He was just an interventional fellow 3 years ago. So it was John Forrest who presented Rival at Journal Club, and was quite happy to kind of but let me take you through it. Whether you look at diagnostic cath or PCI, and you look at the generation of interventionists when they were trained. So if you look, for example, cohort who finished their training in 2011, this is their adoption of radial access PCI. On the other hand, if you look at the more recent cohorts, those that completed their training in 2017, you can see for PCI that numbers are around 70% when they come out of training. And for diagnostic cath, it's even higher than that. So I think it's fair to say that from the Rival trial till now, it's become much more mainstream, and certainly current trainees, we're now kind of even 4 years ahead of this data, are very comfortable with doing radial PCI and very cognizant of the benefits of radial access for diagnostic cath and PCI. So the adoption is there. The training programs are adequate. They're getting, you guys as trainees are getting plenty of exposure. And it looks from the data that you're very comfortable to kind of do this when you exit training and start your own practice. And radial access is now part of all guidelines. In 2017, the ESC recommended it as class 1 level of evidence A for STEMI PCI. And then they extended that to NSTEMI in 2020. And the US behind the curve a little bit compared to Europe, kind of all the guidelines in 2021 said that radial access was indicated preferentially over transfemoral in both ACS and in stable ischemic heart disease. The complication of avoidance is for mortality benefit in ACS, and for stable ischemic heart disease, it's for vascular complications, especially bleeding. So I think, we've come there now, and we're all kind of on the same line. The only other study I wanted to spend time on is Safari's, because Safari was published last year and generated some degree of controversy. And, I think it's important just to kind of make sure people understand that trial and what it said and didn't say about radial access and STEMI. So this is a study which was funded through the Canadian Institutes of Health Research. And it was looking the original intent was to look at bleeding complications in STEMI PCI, which is why they used bivalirudin. I think part of the study's rationale was to say, look, if we use bival, transfemoral and transradial are the same. Somewhere along the way, the primary endpoint shifted to all-cause mortality at 30 days, and I don't know the backstory there to tell you why the endpoint was changed. But the planned interim analysis at 33%, the data monitoring committee stopped the trial for futility. And so instead of having almost 5,000 patients, they ended up enrolling about 2,300 patients. And it was at 5 busy PCI centers in Canada, and the data coordinating center was at the University of Ottawa. So this is the punchline. If you look at their primary endpoint, all-cause 30-day mortality was no different between radial and femoral. And the mortality numbers are very low, 1.4%, which is really phenomenal for STEMI population at 30 days. The bleeding events were likewise really low. There was separation between radial and femoral, but didn't achieve statistical significance just because the numbers were not there to kind of reach that. So that you will hear about Safari. I think it's kind of hard to make much sense of it since they didn't enroll all the patients they wanted to. I think it's a little difficult to translate this because it's at 5 kind of high volume PCI centers. They only use bivalirudin. Maybe it's cheaper in Canada to use bivalirudin, I don't know. But I think it's important that I kind of mention, I think, it's hard to put this into the correct context. And then hot off the presses is this from last week or the week before. So this is a meta-analysis which includes Safari and Rival. So it includes 2 negative trials, as well as Matrix and several other well-known radial versus femoral trials to get to over 20,000 patients. And this has only been released in online form. It hasn't been published yet. So we don't have all the information. It's 95% acute coronary syndrome. The co-primary endpoints of this analysis were all-cause mortality and bleeding. And this is all-cause mortality, which was statistically significant. Again, the mortality figures are impressively low. I guess which you would expect in kind of clinical trials, a little bit of a select population. The bleeding graph was not available online. You can see I pilfered this from the preprint version online. So we'll kind of wait to see what the final version of this is, but I think, my conclusion of the radial-femoral debate is that you have to have both skill sets. There's clearly some patients that you can't do radial on. And I think the preference for radial is of benefit for bleeding and mortality if the choices are equal. So I'll leave the data there to say that I think we're kind of at the end of this long trial at a safe place where radial is preferred. Okay, so that's the data. Now I just want to spend the next.
Can you just comment on sort of the risks of stroke and the evidence or not for that in radial versus femoral?
Yeah, that's a good question, Jeff. The last time I looked at the risk of stroke, transradial, transfemoral, there was no difference. And so that was, you're probably better clued into this than I am. That data was from NCDR, but it was kind of, the last time I looked at that was probably 2018 or 2017, and the risk of stroke was equal. The stroke risk was much more defined by the patients and the kind of demographics and comorbidities of the patients. But as far as I'm aware, there's no data that suggests one way is safer than the other. Do you know anything from NCDR?
No, I was just wondering if that meta-analysis had stroke as a secondary endpoint, and if there was something that emerged from that. But as far as I know, they're equivalent, albeit heuristically, it seems like it's still higher.
In radial?
In my hands.
All right. Yeah, so that has been a point of debate, but as I said, the last time I looked at that, and it was 2017 or 2018, and that the data that I was looking at was even before that. So I'll go back and see if I can find anything. All right, on to my biased points of view. So there's a lot of discussion at meetings and in the literature about whether left or right radial is preferred. There are some operators who are biased towards left. For most of us, the right is preferred, and I think most of the literature is, right radial access. But I think there's some important considerations favoring left radial. Patient height is definitely a factor. My own bias is patient age, and then, for lack of a better term, I'll say body mass distribution. So height, there's actually some data on. This is from Sunil Rao, which shows that the shorter the patient, the more likely you are to fail at getting a guide catheter to engage from the right radial. So this is specifically PCI failure rate from the right radial, 165 centimeters. I'm pretty sure it's about 5'4". Anybody want to translate for me? They can. And then 175 centimeters is about 5'8" or 5'9", I'm pretty sure. So once you get up to kind of 5'8" or 5'9", the right radial is pretty successful most of the time, still a 2% failure rate. So, but that really escalates in short people. So especially women tend to be 5'4" and below. I think you have to kind of be very cautious about. And then aging, this is an MRI study. The age range is not that great, but I think it's a nice demonstration that of two things. First of all, with age, the ascending aorta lengthens, and that has and widens, gets larger, and that has the effect that it pushes the aortic valve down and makes the heart more horizontal, so that the left coronary ends up being somewhat superior. But the arch also opens and expands. The aorta is kind of fixed at the diaphragm. And so as it lengthens and enlarges, this curve necessarily has to expand. And it's not demonstrated very well here, but that effect of that opening of the arch tends to put the innominate more towards the descending part of the thoracic aorta. And so that can introduce a real curve here if you come in from the right. So 64, I think I'd still go right all the time, but my cutoff is around 75. You have to be very careful, especially in somebody who has either very long-standing hypertension or aortic valve disease, aortic stenosis. I think that changes the game in terms of the aorta as well. And so once you give it above 75, my bias is to go left radial, unless you have a CT that shows you that the relationship between the innominate and the ascending thoracic aorta is favorable. So just, something to be thinking about as you decide left or right radial. And then obesity has the effect of kind of making people short in terms of their chest contents. So, as abdominal obesity increases, the diaphragm gets pushed up, the apex of the heart moves laterally and towards the armpit. And so the coronary angles can be much different in overweight people, and the ascending thoracic aorta can be effectively shortened. Sometimes you can overcome that with deep breathing. If you're able to get them to move their diaphragm south, it kind of may correct anatomy. But very obese people are more like short people, and so left radial may be favorable in them. They also have the additional challenge of reaching over their abdominal obesity if you go left radial. So it's a balance for sure there, but I just put that out there as kind of my bias, that that's another reason to think about the relationship between the innominate and the thoracic aorta. My other bias is on this concept, or this idea of radial spasm. If you look in the literature, radial spasm occurs in 10 to 15% of cases, but there's no universal definition of spasm. Is it pain? Is it inability to torque catheters? Is it inability to advance a guide into the aorta? So when you read about spasm, it's kind of a mishmash of a bunch of things, but pain's kind of a universal term. There's a bunch of identifiable risk factors: low body weight, younger age, female gender, which younger age, I think that's probably true. Gender and body weight kind of, I think, disappear as you get older. And there's a bunch of ways to work around quote unquote spasm, including more sedation and intra-arterial drugs, cocktails to prevent it. And this is kind of just a summary. There's so many studies out there, all kind of equally poorly done, all kind of from single centers or a limited number of centers. And I think the numbers that I would point out here is that with placebo, in this summary of a bunch of different studies, so this is 1,300 total patients in this sample. I think I don't have the total number here. Sorry, I don't know the total number, but 640 placebo, the incidence of radial artery spasm is 12%. And, depending on what drug you give, verapamil, nitroglycerin, it can go down to the low single digits, 2 or 4%. So, my own bias is, I think a lot of what we call spasm is in fact not spasm. I think when somebody has forearm pain, we do lots of things in addition to giving intra-arterial drugs. But I would argue that there's often other things. And so it's important to consider this, but also think about potential confounders. And so the radial anatomy is important to think about when you go from the arm. This is the way it's supposed to be. The radial is supposed to connect near the elbow with the ulnar to form the brachial above the elbow. And, if your 23 centimeter sheath gets you here, then you have kind of a short course to get to the brachial. But very oftentimes when people have pain, it turns out they have an accessory radial, or the radial connects up higher on the brachial or axillary artery. And this part of the radial is often very small, very tortuous, and gives patients pain when you're trying to move a catheter through this long, skinny artery. And so I'll just show you a couple of examples. These are examples from our experience at the VA. Here's the radial artery coming up here, and then this is the ulnar, and this is the brachial. And there's this accessory radial which goes all the way up here and connects, and there's this loopy connection here. So in this case, it's kind of easy. If you kind of see this and know, then you can get a wire around here and get into the brachial and get around and get where you need to be. This patient had pain in biceps, when we did the diagnostic, the wire went straight up here, the diagnostic catheter went fine. And then we tried to push the guide up and he had a lot of pain. So that pain was not spasm. It was just that we were trying to shove a guide through a really small, long artery here. And once we corrected and went into the brachial, everything went smoothly. This is another example that's not so easy, but it's the same situation. You have the radial coming up from the forearm. This is actually an accessory radial. And over here, you just see a hint of it is the formation of the brachial. This is the ulnar going down this way. This connection between the radial and the brachial is 360 degrees. And so this is a full circle. I tried early on to kind of navigate these, but this is really hard to straighten out in most cases. And so when I see this degree of a loop connection between the radial and the brachial, I just kind of transition to femoral. I think it's worth your time to just cut your losses and go femoral in that case. This is kind of one of those cases where I persisted. We went with a angled glide wire. We got around the loop, and you can see how the loop straightens out when we push the Jackie catheter through the loop. So this is a full 360, and we're able to kind of navigate and then straighten it out. This is kind of a young person. The arteries were pretty flexible, but they were uncomfortable when that radial loop was straightened out. And we ended up going transfemoral for the intervention part. This is a diagnostic catheter. So you can do it, but it can be technically a pain in the neck, and then the patients aren't that comfortable. You can also have loops in the brachial artery. These also usually can be straightened out, getting a wire through. And you can, because the brachial is so much larger, you can kind of achieve your goals and get through it and do the intervention. The only problem with straightening a brachial loop like this is that the blood flow through a straightened loop is not very brisk. And so the patient's arm kind of goes numb. So if you have a long procedure, a long intervention, they can be pretty uncomfortable by the end. So I would just caution you, if the patient has pain, it may be spasm, but I think it's important to kind of make sure you're not dealing with a loop or an accessory radial. And so above the elbow, pain in the bicep is a kind of a strong indicator that you're in one of those accessory radial arteries. And it's important to kind of do an angiogram and see if that's the case and how you can get back into the brachial. Below the elbow, it may be that they have spasm, but you may just have a small artery, and it's amazing. They have a lot of pain with the diagnostic, but if you use some of these other techniques to get past that, either balloon-assisted tracking if your guide, or some kind of other catheter through in a mother and child kind of situation with your guide, such as a glide catheter or a multi-purpose diagnostic catheter, then most of the time you get through with no pain at all. It really changes the game. And then the other thing, which is really impressive, is sheathless guides. That we kind of had a period of using a lot of sheathless guides at the VA. We've kind of moved away from that and gone to just standard 7 French guides. The downside of the sheathless guide, they're very slippery and they can get around tortuosity real well, but then they're kind of slippery and they don't give you good support. So if you have a tough case, you end up using a guideliner quite a bit. But there's definitely ways to get around the spasm pain or the pain below the elbow. So I think if there was a real objective way to define radial spasm, that we'd have better information. But I just caution you that spasm is, in my biased opinion, is often not spasm. And then again, I think ulnar access, we don't use enough. You can use, if you've lost the radial artery, you can use the ulnar on the same side without fear of ischemia. Those studies have been done. The data is pretty robust. I think worldwide data on ulnar access is pretty strong. It's best to use ultrasound. The ulnar artery is close to the ulnar nerve. It's deeper. It's more mobile than the radial artery. So, you have to use ultrasound. But I think it's just as useful and just as safe. But don't forget to flip the TR band upside down. You're on the other side of the wrist on the right, and then right side up on the left. All right, we'll just get to the last few minutes here discussing radial artery occlusion and distal radial access. And so radial artery occlusion, depending on what you look at, is anywhere from 3 to 10%. It's definitely more common in patients who have pain, spasm, or you don't give enough heparin. And it's definitely associated with smaller arteries, especially if you try to use bigger sheaths in smaller arteries. So one of the recommendations is to try to really make your sheath as small as possible in small people with small radial arteries. And the slender sheaths are more expensive, but we kind of default to those, which I think is great. You should just default to 100% slender sheaths, unless you have somebody who's really large or has huge forearms and a big radial artery. And this is just kind of, I put this data out. This is kind of a systemic review, but so there's lots of data points. But this shows you that radial artery occlusion by ultrasound is about 7% on day 1. It goes up to 10% days 2 to 6. And then with no specific treatment, if you look out beyond 7 days, it's down to around 6%. So the artery is able to recannulate. They may go home with an occluded radial. There's things you can do to improve that recanalization rate. The most common symptoms with radial artery occlusion are forearm tenderness, some inflammation. Some people get a little warmth or redness over the radial artery. The strategies to prevent it are make sure you give enough heparin. For a long time, early on, we were giving heparin intra-arterially, which is really painful. Then we weren't giving enough. So I think at least 3,000 units for smaller people, and larger people over 70 kilos, at least 4,000 units. As we know for diagnostics, there's really no downside to more heparin. Bleeding complications are so infrequent. I think the real reason not to give too much more than 4,000 or 5,000 is if you have to flip to femoral access, then that may make things more complicated, although there's not a good data on that. And then this concept of patent hemostasis, early removal of the compression device and shorter compression times. This is just showing that, larger heparin doses, 5,000 units, are better if you do ulnar compression. So you flip the TR band around after you achieve radial hemostasis and compress the ulnar, then your radial artery occlusion rate goes way low. And this is from the Prophet trial. Most of you have seen this already, but basically you achieve hemostasis, make sure you have a pulse distal. You can put a O2 sat detection device on the thumb, make sure you have a good pleth signal. If you don't, then compress the ulnar artery at the wrist to kind of make sure that you encourage radial blood flow. And you really want the hemostatic device at its lowest point for as short as possible. Can you give anticoagulation if you have radial artery occlusion? Yes. This shows the effect of 7 days of rivaroxaban after the procedure, which lowers the radial artery occlusion rate at 1 month from 11% to 3%. So they gave rivaroxaban to everybody. I don't think that they just enrolled people who had evidence of radial artery occlusion. So there is some data that if you have somebody with an occluded radial when they go home, maybe a short course of rivaroxaban would be helpful. But Dr. Kimine, still going after all these years, he felt that radial artery occlusion remained the Achilles heel of radial access. And so this is his report of using left distal radial access in 2017, the anatomic snuff box. And in his paper, which I'm pretty sure he was this only author in this paper in neurointervention, was that number one, it was convenient for the operator because you could bring the hand closer to the right side of the bed where you're standing. Number two, it improved patient position comfort because instead of trying to bring the arm across with the palm facing up, you could have the palm down, which is for most people is kind of a natural position if you lay your hand across the body. He also was very keen on this shortened hemostasis time. He recognized in this paper that it was not possible in all cases to use radial compression devices. They didn't fit as well, but tape and rolled up gauze worked very well, and most of the time there was shortened hemostasis. And he hypothesized that there will be less radial artery occlusion. And I think, I don't remember if he gave data to that effect, but this is only a report of 70 cases or so where he said it was technically feasible. So why would it have less radial artery occlusion? The key thing is to understand where you get it. So this is the anatomic snuff box. Here's the distal radial artery. And if we look at this diagram of the hand, this is where you're going to get access in the distal radial artery. And it's after this branch of the superficial palmar arch. So even when you're compressing this spot, even when you have access here, radial artery flow is maintained. And if you lose this branch, then the hand supply is intact because of the palmar arch. There's really no ischemia, and you preserve the radial artery. There's less radial artery occlusion. So that was his hypothesis, one of the major reasons that he wanted to use this or adopt this alternate radial access. And both of these studies, I'm pretty sure from either 2021 or 2022, single center studies, both of them showing kind of a pretty dramatic reduction in radial artery occlusion using distal radial access. So provocative because, the radial artery, preserving the radial artery is so important for future access, for vascular access, for dialysis, for example, in patients who have compromised renal function, or to use it as a conduit in bypass surgery in those countries, in those institutions that harvest radials for coronary surgery. The disco radial trial was just published this year, though, and this is the first kind of multi-center randomized study to kind of examine this question of radial artery occlusion in a pretty careful and formal way. They anticipated a radial artery occlusion rate of low, 3.5% in the normal access and 1% in distal radial. 100% of them used slender glide sheaths. And the primary endpoint was radial artery occlusion by Doppler signal at discharge, which is a very early time point. Some of these patients had their discharge 8 hours after their intervention, and up to 48 hours after the procedure. And this is their, primary slide. And I just want to bring your attention to the two panels on the right here, which shows that in traditional transradial access, radial artery occlusion occurred in less than 1%, whether you look at intention to treat or per protocol. Distal radial was less, but did not achieve statistical significance. And it was pretty striking. If you remember back to that slide I showed you where the average radial artery occlusion rate in that big meta-analysis from 2016 was 7% or almost 7%. And here we're looking at radial artery occlusion rates of less than 1%. So I think, this was a really interesting study. It failed to prove the point that distal radial access was better than traditional radial access, but it was also the first study to kind of universally employ pretty rigorous attention to good technique to preserve the radial artery. So, everybody got good ACTs. I think the ACTs are 250 here. Everybody got some kind of spasmolytic treatment, which, as I said before, I'm a little bit unconvinced that it's really necessary, but everybody got some nitrates or calcium agents at the time of sheath placement. They use 100% slender sheaths. They kind of checked for patent hemostasis very rigorously in this study in those patients who had usual access. And they only allowed people who had extensive transradial expertise to be investigators in this trial. One of the criticisms of Rival, if we go back to the first transradial versus transfemoral randomized trial, is that a lot of the operators were not very experienced in transradial PCI. And so they kind of made sure in this trial that everybody had minimum competency in transradial access. So, I think this is from an editorial that accompanied this study that said really what disco radial tells us is that if you pay attention to best strategies to prevent radial artery occlusion, you can drive radial artery occlusion rates very low, less than 1%. It's probably never going to be as good as that in routine practice, but all of these things matter. And perhaps the best takeaway from disco radial is that standard radial access is fine as long as you're really attuned to the patency of that artery in the recovery period. And for those of us who have tried to use distal radial artery access more routinely, it is difficult. It's technically very challenging. It requires ultrasound and it requires more time up front. And it can be frustrating to say the least. But I think, except in real exceptional circumstances, I think you can use standard radial access without too many downsides. So I'll conclude there just to kind of say that I think we can all agree that radial access is mainstream and ulnar should be considered, forearm arterial access. It's just as good of a place to get in. There is a clear mortality advantage over transfemoral, especially in STEMI, especially in ACS. I think the data is pretty powerful at this point to make that, and that's why it took until 2021 for DHA, ACC, and SCI all to say that this is the preferred access. So I think there should be no debate on that now. I think that it's important to kind of make sure that you choose those for left radial access carefully. Bypass angiography is important. That's the major reason that most people select radial, but I would also caution you that you will be happier in your older patients and your shorter patients going left over right. If you have a CT scan to look at, then that makes everything easy. The calculus kind of goes away. You can just see the relationship. But otherwise, you need to kind of consider those things. Beware of the anatomic variations of radial arteries masquerading as spasm. Take an angiogram early. Go a little RAO when you do your angiogram to see the connection between the radial artery and the brachial artery. And I think, best practices for taking care of that artery during the procedure and immediately after can really dramatically decrease the incidence of radial artery occlusion, which is important and does have implications for that patient for future cardiology procedures, but also other procedures and their medical care in the long term. So I think that's my last slide, and I'd be happy to take any questions if there are any at this point. Thank you.
Thank you, Dr. That was a great updated review. Does anybody have any questions?
Karthik put in the chat there the stroke risk, no difference, radial.
Yeah, in the paper that you mentioned. Yeah.
Okay, thanks, Karthik, for getting that.
Dr. Pfau, this is Sumit. Any thoughts on the setup for left radial? So it's very different for what we do at the West Haven VA compared to what's done at the Yale campuses. Any suggestions or best practices?
So there's no data on best practices as far as I'm aware. I think somebody along the way clued me into the finger traps, which I still believe. We have a nice elbow support thing that we kind of use at the VA to kind of push the upper arm over. At Yale, pillows and arm boards, in my estimation, are less stable, but also there's some capital investment to kind of get the right stuff. So I don't think it matters that much as long as you're comfortable with how it is and the patient can stand it, and their left radial doesn't end up off the table on the left side during the procedure. So I don't have any comments except to say that everybody has to find the way that works for the patients and works for the cath lab staff and works for the operators to make sure you have a stable position for left radial access. There's some operators who work from the left side of the bed in left radial access. In our environment where we so rarely do that can be really disorienting. So I don't recommend that, but there's a bunch of ways to get that done, and it's completely dependent on your lab and what your resources are.
Dr. Pfau, this is Daniel.
Hi, Daniel. How are you?
I'm good. Thank you for the talk. Great summary.
Thank you.
One question I have: in your practice, when do you acquire a radial angiogram? After access in all cases, or when you face difficulties going up with the catheters, or when the patient feels pain? When do you recommend an angiographic?
Yeah, that's a great question. Let me clarify, because I kind of wasn't very specific about that. So I don't think it's necessary 100% of the time. Most of the time it's not necessary. Everything goes smoothly, and so I wouldn't plan radial angiography. I think the main thing is, especially when that patient has pain above the elbow. So if they have pain, either in the lower part of the upper arm or even in the bicep area, almost certainly that's an anatomic variant. And so you need an angiogram to make sure that you can get into the brachial. Below the elbow, you have to be very cautious. I had some kind of dramatic videos, which I took out of this talk, where people did injections when there was spasm and they didn't have a good waveform in the radial sheath. And you get these very impressive, impressive extravasation. It turns out that as bad as the angiogram looks, those patients do quite well, but you just have to be careful. So I guess the short answer is 100% when the patient has pain above the elbow, or when you can't get the wire into the central aorta and you're kind of wondering where you're getting stuck.
Thank you.
Hey, Steve. Hi. Thanks for a great talk. I was just wondering what your thoughts might be on the contemporary practices of ultrasound guidance for femoral access, and if that was to be utilized in several of these trials, if that would make a difference in terms of the bleeding complications. So just was wondering what your thoughts were.
Yeah, thanks, Asim. Again, this is my biased opinion and not any data. We've all moved to the micropuncture technique, 100%. That was a transition that occurred probably around 2010 or 2011. And now we're kind of moving to 100% radial ultrasound for femoral access. But I don't think that that will eliminate the bleeding complications we see with transfemoral. There's something that happens, and we've all lived through retroperitoneal bleeds. It can be, the retroperitoneal bleed can be on the other side, it can be in that abdominal aorta, and I don't understand. It's not that some wire went somewhere and we didn't recognize it and it perfed something. There's just something about transfemoral access, even when you access it in the right spot anatomically, that predisposes to bleeding complications. And contrast nephropathy is worse for unexplained reasons by transfemoral. Even CC per CC, the same contrast volume gives more AKI from femoral rather than radial. So I don't have an explanation except to say that my own bias is that ultrasound access of transfemoral will not change the needle in terms of the bleeding differences.
Thank you.
Dr. Pfau, one of the criticisms of the Safari STEMI trial was also that, some of the high-risk bleeding population was excluded, like bypass surgery and people on anticoagulants. They were also excluded from the trial. So, those are sort of the groups in which we would stand to benefit more. And also, IABP and these kind of related complications in the radial arm were also attributed to bleeding to radial, which is obviously not the case. So there were some, obviously people will always find criticisms about every trial, but these were the ones for Safari STEMI. So we do pretty good in radial access. At Yale New Haven Hospital, we, last I saw, it was like upwards of 70% is radial now. I don't know what it is nationally. I think the last NCDR, like 2019 or early 2020 data was suggesting 40% is nationally radial use. So we're definitely doing pretty good. I was up in Michigan a week or so ago, and there's still a lot of operators. I went to meet a friend there, so there are a lot of operators who are still doing 100% femoral. So, there are still several naysayers, and so.
Yeah, it's taken a while. I just want to say that it wasn't a smooth road, that's for sure. But I also want to give credit to